Hello, everyone. I'm Dr. Angela Mattke, and you're watching Ask the Mayo Mom on Mayo Clinic's Facebook Live. I'm a pediatrician at the Mayo Clinic Children's Center in Rochester, Minnesota. If this is your first time watching, thanks for joining us. Twice per month, I host a show about pediatric health topics where we take and answer your questions live. Today, we're discussing chest wall deformities in children, which include a variety of different types of anomalies that we will get to shortly. Please send in your questions now so we can answer them during our live show. Joining me today to discuss chest wall deformities is Dr. Denise Klinkner. Dr. Klinkner is a pediatric surgeon at Mayo Clinic Children's Center, where she's also the director of the Level 1 Pediatric Trauma Center and an assistant professor of surgery. Dr. Klinkner also does outreach at Mayo Clinic Health System in Mankato. Dr. Klinkner, thank you so much for joining me today.
Thank you for having me.
I think this is going to be a good discussion. So tell me, how do you determine which types of chest wall deformities that there are, and what are some of their names and how they manifest?
Well, I think parents will see them even as early as infancy. The two different types that are the main ones we treat surgically include pectus excavatum and pectus carinatum.
Okay.
Pectus excavatum, I think of an excavator, so there's a little hole in the chest, and the patients may not notice any other symptoms other than that there's this, space that's there. 80% of the patients actually have pectus excavatum, and then carinatum is the old-fashioned pigeon chest where it sticks out more. That one's about 20% of the time.
Okay, so how common are these chest wall deformities especially of the pectus types, the two different types?
They can, depending on what literature you look at, they can range between 1 in 150 to 1 in 1,000.
Okay.
So the average most people quote is about 1 in 400.
Okay.
Whether or not they all need a surgical treatment is different. Most carinatums actually respond really well to bracing.
Okay. So excavatum is more likely to need maybe surgical intervention, is that right? Okay. How do you said they present in infancy. Will they progress or get worse as the child gets older, or are they going to stay the same?
Well, even though we see them in infancy, we don't do any treatment at that time because some will be exactly the same as they grow up.
Okay.
As they hit puberty is the usual time for progression, where it will either get significantly worse and they'll say, oh my goodness, in the last 6 months it's like significantly different. And I'm like, well, did they have a growth spurt? And they'll say, oh yeah, actually they just had a growth spurt. They grew, through 2 or 3 inches, and that's when they'll notice it. The time to treat it is nice in that age between 12 and 14 years old because their chest wall is still flexible.
Okay. Do you want to try and do the surgical treatment for the excavatum before they go through that growth spurt, or is that timing not important?
So the different types of surgical intervention for excavatum was first developed by Dr. Nuss. He was doing them as young as 2 years of age. The problem was that because they hadn't reached chest wall maturity, meaning close to what they would be when they're a full-grown adult, they would get a band where that bar was. Okay. And then it was restrictive when the whole point of doing the bar was to increase the diameter of the chest and allow the lungs to work better.
Okay.
So we do prefer to do them later.
What about... is there a way to predict which ones are going to progress and get worse, or which ones will maybe not get worse or maybe even regress a little bit? Is there any way that you can tell?
We will follow them on an annual basis based on chest x-rays.
Okay. Do you do any other type of measurements or like rating scales or indexes to determine how severe their pectus deformity is?
There's an index called the Haller Index that looks at the distance between the sternum and the spine, which in excavatum becomes very narrow and pushes the heart off to the side. And then the width of the chest. And when we divide that, if that number is greater than 3.25, then that's considered a severe pectus. The higher the number, the more severe it is.
Okay. Well, we have a question here from the audience that kind of going into what we're talking about with the depth of that indentation. And this person is asking if that indentation or the excavatum that we're talking about isn't very deep, can they grow out of it? or will they need surgery? So this is kind of what we're getting at here. Is there a way to give a parent a clear-cut answer regarding it?
If it is not very deep and the Haller index is less than 3.25, we recommend exercises. Part of what people will do to hide the defect is slouch their shoulders and try to not make it so obvious. The problem, is obviously we want to strengthen the core muscles. That will decrease the flaring of the lower ribs, and the increasing the strength of the pectus will also pectus muscles will also make things more more appealing from a cosmetic standpoint.
Do these exercises need to be started before adolescence, before they go through their growth spurt, or is it something that you can start kind of later on as you see it getting more progressing?
We do those exercises, start them when we see them in clinic.
For the first time, okay.
And then after surgery, we let them heal for a period of time, and then they start them again.
Okay.
So it is something that, whether or not you have surgery, we recommend them.
Is this something where they need to also incorporate physical therapy with this, or are they able to do it kind of on their own at home? We
have a pamphlet that we hand out, and it includes very easy directions. It's all things we probably should be doing anyway.
Okay. Just to strengthen the core and the back and stuff. So you mentioned that you use x-rays to follow the progression. What about, is there a role for needing a CAT scan or a CT scan to monitor this progression or not?
Well, in this day, we're trying to avoid radiation risk for children. So the use of CT scan at our institution is limited to patients who have an allergy to a metal, because the bar, if they have an allergy to that bar, they'll get reactions to it. You'll have to take it out, and if you take it out too soon, the defect will recur. So the purpose of the CT scan is to send it to the company to design that individual patient's own titanium bar.
And do you do that with every patient?
Not only the ones that have an allergy.
Okay, gotcha.
And knock on wood, it's very uncommon.
Okay, gotcha. So what about, other than it just being cosmetically maybe undesirable for the person to have the indentation of the chest or the chest going outwards, are there other medical things that can be associated with this or cause problems for their health?
Some children will not have any symptoms. Some will have shortness of breath. Some patients will have even palpitations or regular heartbeat. Other patients will just have fatigue, which is somewhat a vague symptom. But if you cannot breathe in as well as you would otherwise, I think we make sure that it's not another problem by doing pulmonary function tests. And then for those that have cardiac symptoms, we would proceed with an electrocardiogram and an echo. But that's not for all patients. Our typical clinic patient will get a chest x-ray, pulmonary function test, and metal testing, and then go from there depending on what symptoms they have.
Okay. Do you need to bring any other members into your team? So as a pediatric surgeon, I imagine that you're kind of driving the ship for determining surgery, not surgery, and their aftercare. But is there anybody else involved in planning or aftercare?
We use our pain service. The pediatric anesthesiology team has developed a very nice protocol of using paravertebral blocks. And those are similar to an epidural in that it goes near the spine, but it doesn't actually go into that space. So the family can actually take care of this at home, and they can pull those lines at home.
Wow.
And that means they get to go home on post-operative day number 2 instead of post-operative day 4 or 5.
And this is something that you guys have actually studied and published the results on, being able to shorten the duration of their hospital stay and pain levels, I understand, right?
Oh, yes. Dr. Hiley has been the lead from the pediatric anesthesiology side of things. And that, I think from all the different places that I've been and trained, it's one of the nicer things. People will either do a patient-controlled analgesia button, or they'll do epidurals, and that transition has always been difficult. And we've been able to avoid that.
That's fantastic. We have another question from an audience member here. They're wondering if there are any other health risks, more kind of, I think internal probably is what they're referring to regarding to pulmonary or cardiac, in adulthood if that chest wall deformity is untreated.
I think it depends on how severe it is. The symptoms may become worse. Some patients do end up with a mitral valve prolapse. So we would be able to document that on an echo. There are adults who do get the repair. And even though I'm, quote, a pediatric surgeon, we've taken care of patients into adulthood.
Are there any difference in outcomes if you were to do it sooner rather than wait till adulthood to have the repair done for their long-term health outcomes?
I think the benefit of doing it in puberty is that the chest wall is still flexible. We're not, quote, set in our ways. We haven't calcified, right?
Right, exactly.
And so it's easier recovery. It's easier overall. And the bar, so the treatment is to place a bar under the sternum and lift it. We leave that in for about 2.5 years. Depending on how mature the chest wall is, it might stay longer because we don't want a recurrence. But once we take it out, patients go on their way, and they do very well.
Awesome.
We did a recent study to look at outcomes from a cosmetic standpoint. How many of our patients actually need a plastic surgery consult specifically? We had over 400 patients that we reviewed and that underwent surgery. So there's several more that we see and that don't need surgery. So we don't recommend it for everybody. But only 5% of those patients needed something else. And of that 5%, several of them were noted beforehand to have asymmetry of the chest that was not going to be corrected by the bar. So the plastic surgeons were involved for that. But for something that people see as a cosmetic problem, families and children are very satisfied with their outcomes and usually do not require other interventions.
That's fantastic. You know, you've mentioned cosmetic kind of outcome, but is this something that can be covered by insurance? Because there are so many other medical applications and how this can affect their life and their functioning.
The insurance process, does require some pre-qualification. So there's at least a 2-week lag between a consultation and approval. But if the Haller Index meets criteria along with symptoms, we usually don't have a problem getting it to be covered by insurance.
Are there any other types of things, medical conditions or medical diagnoses or anomalies that go along with having the pectus deformity?
Yes, it's not a lot of them, but we have to be sure to note whether or not they have Marfan syndrome, where they have really long fingers, because they're in Ehlers-Danlos or connective tissue disorders. And the difficulty is these are patients that may need cardiac surgery, and we want to time the correction, because if you take the bar out too soon, they'll recur, and then to go back after sternotomy is a little tricky.
You'd mentioned like the optimal time for surgical intervention, but can you just clarify that again? We have an audience member asking that question, and especially the bar, and then I want to get into talking about what the surgery actually is and how you do it.
So from our standpoint, around 12 to 14 is a time period when the child is getting closer to the adult skeletal size, so that the bar doesn't restrict the growth the way it should.
So if you were parents, and we had a question on Facebook earlier talking about, they were concerned about their child having pectus deformity and wanted to bring it up to their provider. If they were to bring it up from their provider, where would be the next step that they would need to be referred to if there is a concern based on that index?
Well, we don't need a direct referral for patients to come to our clinic. So families can actually call directly and get an appointment if there's a question or concern. We certainly see patients when they're younger. We try to delay the surgery because I think that overall the outcomes are better. The patients with carinatum, for example, those we would potentially do just a little bit younger, because getting the brace to fit and then have them grow, it's like your teeth, right? You want it to kind of gradually adjust over time, and then they actually do very well and have no anesthetic risk, no scarring, as long as they're compliant with using their brace.
Okay. And how long are we talking about that brace usage for the carnatum type of practice?
So they can, depending on how effectively they are using it, they can see a result within 6 months.
Wow.
And then we treat it like a retainer for your teeth. You have to use it usually just at nighttime to kind of keep it in that position until they're done growing through their growth spurts.
Okay. So let's talk about the pectus excavatum surgery. Tell us about what you guys are doing during that surgery. Take us through it.
Well, there's 2 different operations. The original operation was called a ravage. It sounds really barbaric, but the technique is to remove segments of cartilage, because the problem with the deformity is that it's the cartilage that's overgrowing.
Yeah.
And so we remove segments of that cartilage along the sternum, and then the sternum's usually twisted, so we have to literally break that sternum and lay it flat. So we put a bar underneath the sternum to keep it lifted so it doesn't sink back down. That bar only needs to stay in 6 months because we have physically altered the cartilage.
Okay.
That operation can take 6 to 8 hours, so it's a lot more technically demanding type of procedure. But some are not as happy with having the scar in the middle of the chest.
Okay.
So Dr. Noss came up with the Noss procedure, which he used to do blind.
Okay.
You pass a bar from one side of the chest to the other. We don't do that anymore.
Blind, yeah. You probably have other ways to look, right?
So we now use a thoracoscope, which is a 5 millimeter instrument, just to watch that dissection. We're trying to get into a plane between the sternum and the pericardium.
Okay.
And slide our way through, and the problem is it's dipping down, and so it's hard to see underneath to the sternum.
Okay.
So I prefer to watch and make sure that we're going in the right place.
Okay. So you get the bar in, you're able to then kind of close up the patient, is that right? Okay.
Yeah, there's an incision on both sides, and then an extra little 5 millimeter incision for the camera.
Wow. So it's just 3 tiny incisions then is all they end up with. That's great. And nothing in the middle of their chest.
Correct.
Wow. So then you said there's a second procedure to go back in and remove the bar.
Yes, and we have to reopen both sides because we have to unbend the bar to like slide it out.
Okay.
But that's usually an outpatient procedure. They just go home the same day.
Wow. So that one's a lot shorter, I imagine, not the 6 to 8 hours of the initial procedure.
Yes, and it's not nearly as painful because the chest is what it is.
Yeah, fantastic. So we have a question here from the audience asking about the risks and the benefits from repairing. So what kind of risks do you have to counsel your patients about?
Well, the most infrequent but serious complication would be injury to the heart or the lungs. Okay. That's why we watch as we go through, because before there were significant injuries and even death related to it. Wow. It's less than 0.3% of the time that you'd have a cardiac injury. And as long as it's noted and repaired at that time, patients will do fine. Okay. It's one of those rare things, but it's an important thing. You know, the benefit, it's hard to quantify. Sometimes we've been trying to do different studies to see which will work best. Sometimes patient pulmonary function tests will demonstrate an improvement. The patients report better stamina, and so how much that's a placebo effect is hard to say. Okay. But I think that there's clearly a psychological component. You know,
as there is in most things.
Yeah. And patients that after surgery, I know, are very happy because they'll be wearing no shirt.
Right. Yeah.
And they're just
it's boosting their confidence, and that's going to go and help improve mood and everything else with it. And if you improve your mood, you have probably less pain too. Yeah. So that's fantastic. What kind of follow up are you doing other than like the 6 month when you're checking in? How often should the patient expect to be coming back in, getting X-rays?
Well, some things, because we get patients from all over. Some patients will have an X-ray locally and sent to here. Okay. And then we just make sure that the bar has not moved. Okay. And then we try to have them follow up usually here around 6 months, and then a year and intervals.
Okay.
Until we can get the bar, until we can determine that their chest is solid enough that we can take the bar out.
What's the average length that bar is going to be in?
Well, Dr. Moyer likes to leave them in quite a long time, until they're about 20, 21, 22.
Okay.
Most places will do around 2.5 years.
Okay. So anywhere from maybe getting out around 14 if they got it at 12 to maybe 22.
Yeah.
Okay. So
yeah, there's some college students.
Is there any, you mentioned that their pain is usually better and they're feeling better after surgery, but is there any residual problems with the bar when it's in and people complain of any pain associated with it?
That it can happen. The other issues, occasionally you'll find a kid that develops a rib fracture.
Okay.
There are, if the bar is unstable, they'll notice it, because the issue with these kids is they're all tall and thin, so they can feel the bar because they just don't have any subcutaneous fat to cover it.
Right.
We will typically have a stabilizing bar on one side, and then have sutures on the other side that go around the rib to try to keep it in a good position.
Okay. What about after surgery? Are there any restrictions that child wants to get back to sports participation and stuff like that? What do you tell them?
We allow full contact sports, etc., at 6 months.
Okay.
So while there's a favorable time period to come while they're off school in the summer or over winter break, a lot of patients will time it based on their sports schedule.
That makes sense to me. That's what I would have done as a child as well. Okay. What about, we talked a little bit about other anomalies that can be associated with it, but what about congenital diaphragmatic hernia? Is that often, or can they expect any type of chest wall changes associated with that?
Well, congenital diaphragmatic hernia is a disease that's been around for quite some time. The more severe defects, however, weren't surviving until relatively recently. So now that those children with near complete agenesis, where there's no diaphragm at all, they're growing up to puberty and adulthood. And I think of it as a field defect. If there's, they already have a problem with their diaphragm. The lung on that side's not normal, and the lung on the other side's not normal either. So then they are more prone to scoliosis and to pectus deformities. So those patients, I think we're going to be seeing more survivors because we've recently recently established a program for tracheal occlusion to help the lungs grow in that more severe population. So I anticipate that we will be seeing more patients who have both.
Okay. So our filial surgeon here, Dr. Ruano, is doing the tracheal occlusions, and then that's leading to greater lung development and higher survival rates in children that would have died previously. Okay.
Yes, we're intimately involved with that whole program, and recently had 2 successful balloons and deliveries and repairs. Yes, so we're very excited about that program. The most complicated CDH babies often would need ECMO, which is extracorporeal membrane oxygenation. So the machine is giving oxygen to the baby. That rate of ECMO was 80% before FIDO, and it's down to 30% after. So there is a significant change in outcomes, and I'm very excited that we can offer that here.
Are you able to do the diaphragmatic repair earlier if they're not on ECMO?
Yes.
Okay.
Yes, but that's a variable. That's a relatively controversial topic in ped surgery.
We won't get into that then today. We'll save it for another session. How does that sound?
Yes.
I have a different question.
Okay.
Less controversial. Is pectus excavatum? Is there any genetic associations or links that they're able to test for in people?
The ones that we're worried about, Ehlers-Danlos or Marfan's, yes. We don't typically send patients for genetic testing unless there's some other component. Okay. Some families will have more than one generation with it, and the majority, nobody else has anything like this. And then they come back, well, I found out, the cousin so-and-so had this. So.
Okay, so it may run in families, but the gene testing isn't going to really change what we would do unless they had some connective tissue disorder.
Correct.
Okay, sounds good. Well, do you have anything else that you wanted to add about the pectus or some of the surgical interventions?
I think that, the program here is very satisfying for me because patients do well. They have a shorter length of stay, which is less disruptive for families, and they're very satisfied, which is rewarding.
Absolutely, to see those smiles and kids being so pleased and happy. I bet that's incredibly rewarding for your team. Awesome. Well, thank you so much for joining us here today. And thank you everyone in the audience who sent questions both before and during the show. Join us next for our next Ask the Mayo Mom installment on July 27th. It'll be at 10 a.m. Central Standard Time. My guest will be Dr. David Soma, who is a pediatric sports medicine physician, and we will be talking about all things sports. So injuries, prevention of them, concussions, training. We want to answer your questions, and that will help drive our conversation. So please join us and share your questions either on our Twitter account, which is at Mayo Clinic Kids, or on our Facebook page, which is Mayo Clinic Children's Center. Thanks everyone for joining us today, and have a wonderful day.